So good morning. Thanks, David, for invitation and introducing me. Let's say I would like to present you our experience, and as you know, the time is crucial. I try to be a little bit faster to save the time for the meeting. As you know, at the beginning we focused just only for coronary artery stenting because at the moment, at that time there was no thrombectomy device on the market. So our first focus was dedicated to secondary prevention of the ischemic stroke, right? And we published this book, and we followed consequently the patients, and we found that what they didn't estimate it, that if you use the double layer, for example, design of the stent, the risk of restenosis rate from the long-term period is higher. This is what we found. And let me show you my first case. Basically, it was the first case in Slovakia as well. We performed the intra-arterial or endovascular treatment of acute ischemic stroke. It was 71-year-old male, but in very good condition. He was, let's say, some kind of fitness trainer, and we had a discussion. At that moment, there was no imaging guidelines how to do that and how to perfectly select. So we performed the CT as well, perfusion CT, and we took the patient just to confirm the core. At that moment, it was 2004 in March, and finally I crossed this occlusion. I put intra-arterial thrombolysis, and finally I put a stent. So currently we do that quite routinely, but at that moment it was really something, let's say, very aggressive treatment. And what you can see here, at the discharge, there was big improvement of the patient, and he was just discharged nearly without any symptoms. Then we collected the data, and what we found that if you treat the patient with a core or a lesion on diffusion weighted image with volume more than or less than or more than 70 milliliters, you can create or you can achieve different results. So this cutoff criterion was used for a long period then after, and we accepted these guidelines for inclusion criteria. And of course, at the beginning it was aspect score more or equal to 6, like in other parts of the world. But even of big improvement of every steps in this management of the acute ischemic stroke of the patient, even of that, if you see the literature, there is very limited, I mean worldwide, it's very limited access of the patient to endovascular treatment as well to intravenous thrombolysis. And what is the current situation in Slovakia? As you can see here, this is the map of density of population, of location. And the territory is divided to 78 districts. And in 43 of them, I mean this regional city, is located primary stroke centers. The definition of primary stroke centers is that such center must have the access to 24/7 regime to CT and CT perfusion. It's also mandatory to perform CT angio right now. And of course, immediate application of IV thrombolysis after confirming that there is no hemorrhage on CT. It's mandatory. So this is the definition of primary stroke center in my country. Regarding the endovascular centers, there are currently 8. And you can see that regarding the distribution is a little bit different, but again, the highest density of population is located in the west part of Slovakia. So you can see 5 centers are located in this west part. In the middle, we have 2, and there is the only one located in the east. But even of that, if you look to radius, This is the radius of 100 kilometers, so that all the territory of Slovakia is covered. And we use the specific app. You can see the position of the ambulance. Every patient must be, the ambulance must put the data of the patient to this app, so we see the position of the ambulance, so we can be ready immediately after coming the patient. And for example, if we do some procedure, we have time and we have information to not be in the rush and finish correctly and be ready immediately if the patient is arriving to hospital. So it's a big advantage. So as it was mentioned, neurologists collected the data regarding it's a national registry, and the data are shared with the rescue registry. So you can see basically the number of all strokes. I mean, ischemic and as well hemorrhagic are basically stable. And you can see, if you look to ischemic strokes, it was something like 10,000. Some of them are just TIA and regular stroke. You can see the number, something more than 9,000. It was in 2023. And here you can see a little bit more than 9% are hemorrhagic strokes. So at that moment, in 2023, IV thrombolysis was applied to more than 2,000 patients at the moment, and more than 500 joined the bridging therapy. And mechanical thrombectomy was performed in more than 1,000 cases. So if we rate both of them, it's the reperfusion therapy is served for approximately 29% of the patient with stroke. So the percentage is quite good. Regarding the times and the quality we measure, door to needle time, national median is 31 minutes. Onset to needle time is 2 hours and 17 minutes. And door to groin puncture, national median is 30 minutes. So if you look to European countries, IV rate is really nice. It's definitely more than 20%. And here you can see the distribution or the map of the countries according to the rate of IV thrombolysis. And regarding the mechanical thrombectomy rate, is also definitely more than 10% is stable. So we serve this mechanical thrombectomy for more than 10% of the strokes. And here you can see the distribution color map. Again, it's from rescue registry collected by ISO. We use the AI, and not just in my hospital, but in a lot of local hospitals, they use AI as well. It's really good. So we can detect for sure, and we can measure the aspect score. We can detect hemorrhage. By the way, the sensitivity and specificity of the detection of hemorrhage is really very high, nearly to 100%. However, of course, we can use AI for detection of large vessel occlusion on non-contrast CT scans, but the sensitivity in such cases is definitely not as high like detection of hemorrhage. But it's also useful, especially if you have the patient with some kidney disease, and you would like to decrease the risk of nephrotoxicity of the contrast media. So it's really good for that. And in the next future, I think we should focus also for pre-hospital detection of these ischemic symptoms, because nowadays we have not so big space to reduce the time in hospital, how to manage the patient better. But we are losing a lot of time in pre-hospital period before the patient is arriving to the hospital. And AI can be used also for, as it was mentioned in previous lecture, for prediction of thrombectomy success. In the near future, probably we will select the device according to the recommendation of AI, etc. We can predict the final volume and clinical results. And this is really also important because we don't want to do thrombectomy without any clinical improvement. So this is something we should focus in the next future as well. We have been a part of tension trial. As you know, there was an aspect score 3 to 5 and less than 12 hours. And this is what we wanted to achieve, better improvement of clinical symptoms. But I want to mention the one very critical and very important exclusion criteria, which is high-grade stenosis, extracranial high-grade stenosis, and it was not allowed to use the stent in this study. So this is still a good question how to manage such patient when you cannot pass through the stenosis of extracranial stenosis and you need to perform thrombectomy, and just to achieve this occlusion site, you have to place the stent. So this is for the next research. And of course, aspect score 0 to 2 was exclusion criteria as well. But it was the result. As you know, we achieved better clinical results in the endovascular arm, and there was also a big difference if you compare clinical results MRS 0 to 2 as well if you compare 0 to 3. So just independence from another person, there was 18% difference. There was no significant difference according to symptomatic intracranial hemorrhage in this trial, and we achieved lower mortality, significant. Yeah. So you can see it here. And very important part of this study we could find is that 12 months after this treatment, there is still the benefit of endovascular treatment. And what we really like that there is not so significant a part of the patient which are totally dependent to other person or MRS5. So this is really important that thanks to this treatment, we can achieve good clinical result and better functional outcome and lower mortality, as I mentioned. So if you compare all studies focused to large core, you can see some difference according to the time, and as well according to imaging inclusion criteria. So we used mostly only non-contrast CT scan, which is available in every country, and only two, let's say, select two and aspect angel, they used more advanced, let's say, imaging techniques. But you can see better clinical results if you measure it in MRS 0 to 2 or MRS 0 to 3, and mortality rate, as you can see, in our trial was decreased as well. So thanks to collection of these data, nowadays we have meta-analysis which confirms the better or recommendation that we should include also this group of the patient. And this is the recommendation from SWIN. If you have a patient with a stroke onset up to 6 hours, an aspect score 0 to 5, you can perform endovascular treatment. If you have a patient with in a window of 6 to 24 hours, you can an aspect score 3 to 5, you can still perform endovascular treatment, and we need to maybe collect more data if it's really beneficial to perform endovascular treatment in the group of a patient between 6 and 24 hours from the onset, and aspect score 0 to 2. Regarding the pediatric population, if you look to the guidelines, unfortunately, it's very passive, let's say. But what can we say? Thanks to a collection of the data from these two studies, we can see the benefit of endovascular treatment even in this group of the patient, I mean pediatric population. What is the problem? And you should keep in mind, if you want to use, let's say, at least aspiration catheter or as a guiding, outer diameter of 5 French introducer is 2.4 millimeters. But of course, in neonates, you can theoretically use only 4 French introducer and with the outer diameter of 2.1 millimeter. When we check 18 neonates in this time period, you can see a little bit slight difference, between the right and left side and boys and girls. But usually the diameter is just 2.5 or a little bit higher or less. So in such case, be very careful to use the 5 French introducer. But we check, in this case, we performed the thrombectomy in neonates. It was just 2-day-old boy at the time, and you can see how we placed the microcatheter distally, and we performed thrombectomy. And you can see here hypertense median sign. What is interesting, if you compare the volume of the diffusion-weighted image lesion and final infarction volume, there is a difference. Yeah? So our interpretation is that potentially we can treat also this patient, and we think that that this thrombectomy and endovascular treatment was beneficial for the patient. Regarding the clinical results, this patient is, we follow this case. He's able to walk and just normally without any help, and he's 3.5-year-old, able to speak, so it's really important for us. Currently, you can find 3 ongoing trials. This one is very ambitious to collect 12,000 cases of strokes in pediatric population. I'm not sure if they'll be able to do that, but the estimated time to complete this study is end of 2030. And probably we need to decide what will be the next step. Currently, we have the option to transfer the patient to the endovascular center. Another option is to send the team of the physician to primary center. And of course, potentially in the next future, why not to use robotic system and perform thrombectomy remotely? Of course, the limit is the price of this robotic system, etc. But even of that, we are able to, you can see, to perform thrombectomy thanks to robotic system, and as it was demonstrated on silicon model, we try. And so, just to conclude, yeah, cardiac stenting is well-established technique for sure. AI is really helpful. And another very important point, it was a little bit discussed. In my country, it's mandatory that ambulance which transfer the patient from home to primary center must wait for result of the CT, and the same ambulance transfer the same patient to thrombectomy center. And thanks to that, we save a lot of time. And we see that it was very critical step, and I recommend I can recommend you to apply also maybe in your country to decrease the time which is necessary to transfer the patient from home up to endovascular center. And regarding the indications currently, we do accept, of course, aspect 3 to 5, and we do not refuse the pediatric patient. And of course, this is not just thrombectomy. Very important part we did not discuss is then after what we do with the patient after the treatment and rehabilitation, potentially with including of AI for training the speech, etc., will be also a very important part of this healthcare. And if you visit the castle in Orava, in my region, you can find some specific clocks without arms. What does it mean? That the staff which served the service, let's say, or for the emperor was ready anytime to do that. So we should do the same. We have to make a service and a thrombectomy service for our patients anytime, any day in a year. Thank you for your attention.